We'll get started. Good morning to everybody here in the room and to those online. It's really my pleasure to introduce today's speaker for the Grand Rounds, Dr. Collet, and thank you, of course, to our exhibitors, also Janssen Pharmaceuticals and Novartis Pharmaceuticals for supporting our Grand Rounds. Dr. Collet, he completed his education as an interventional cardiologist in the Dante Passanesa Institute of Cardiology in Sao Paulo, Brazil in 2011, and has had dedicated training in cardiac computed tomography and geography at the Holy Cross Hospital in Florida. He continued his education with a doctorate in cardiovascular sciences at the University of Amsterdam. In fact, he completed a PhD thesis focused on integrating coronary imaging and physiology in patients with complex coronary artery disease. He has published over 300 peer-reviewed articles. He's the co-director of the Cath lab at the Cardiovascular Center at Aalst in Belgium. And we're really pleased to have him on CT guidance, speaking of CT guidance for PCI. Carlos actually, when I joined over here, Minneapolis Heart, actually, he's had, because of his expertise in CT, he's been very close to our colleagues, Dr. Cavalcante and Dr. Lesser, and who had indicated that there was this guy in Belgium doing this great work on CT guidance. And since we've really developed a great partnership with our Cath lab here at the Minneapolis Heart Institute, where we will be participating in the P4 trial that I'm sure he'll be talking about during the Grand Rounds today, or a number of other collaborations. And we'll actually have him in Minneapolis a couple of times over the next month for both the initiation of P4 as well as for our CT guided PCI course. So thank you so much, Carlos, for joining us for Grand Rounds.
Yeah, it's a pleasure for me to be here, and let's just start by sharing my screen. And first of all, I think for me it's really an honor to be here, and the reason being that, when you think about how to use CT for PCI, of course you're actually alluding to two different teams that work on the patient, maybe the imagers or the radiologists, and you have, of course, Joao and John there. And then for the PCI, that is, of course, in the Cath lab. And CT-guided PCI is basically an opportunity to collaborate. And I have to say, I have been in many places. In the trial, we have around 25 sites. And I think today that Minneapolis is perhaps the best place for this concept to really be explored and really developed. So that's for that reason, I think I'm very grateful for the opportunity that you guys gave me today. And the title is very simple, CT Guidance for PCI. I like to call this CT Guided PCI to make it shorter and more catchy. And basically, everything started, a few years ago with this. And it is a patient with coronary artery disease, complex coronary artery disease. And this goes to the imagers that are the ones receiving this reconstruction for the first time. And when they see a lot of calcium, they start, it's very difficult to really interpret lesion severity. You can make an estimate, but it's complicated. And this is what is in the mind or in the head of our colleagues when they look at these pictures. But if you are sitting down next to them and you have the same picture in front of you, and I'm speaking now to the interventional cardiologist listening or in the room, you'll be thinking different things. You will be saying, okay, this is a very complicated case. There is calcium from the left main in the bifurcation of the circle, the LAD. There is calcium in the ostium of the right, in the ostium in the mid-segment of the right coronary artery. And basically, you don't need any training, special training as an interventional cardiologist to look at the calcium and the distribution of calcium and understanding before stepping in the lab the complexity of this disease and, of course, the amount of tools or the tools that you will need to tackle these cases. So we quickly realized that one single image had actually two different interpretations and uses within the same patient journey. But I think this is not the case in Minneapolis. I'm sure it's not the case in Minneapolis, but it's the case in many other institutions where the people working and acquiring the CT images are not the same or they don't know anyone in the Cath lab and vice versa. And this, of course, becomes like a maze. You don't know really how to get from the CT to the Cath lab. And this is a problem for trying to incorporate CT in the lab. And what we actually have been working on in the last 5 years, I have to say, is to bridge this gap, how to embed the CT within the diagnostic workflow of any patient coming to the Cath lab. And the results are just unbelievable because of the amount of information that we don't have based on the angio that is very difficult sometimes to extract from intravascular imaging, but are pretty intuitive and easy to see from a CT scanner. And this is going to be the core of the presentation in the next minutes. And everything is because the machines, so the CT scanners, have evolved in a way that are not only allowing to see the lumen, which was something feasible 10, 20 years ago with sufficient accuracy, but the CT scanners have evolved to a moment where we can actually understand the plaque, not only the plaque volume, but the plaque composition. And this is, of course, very important because the only other way that we really have to look at the plaque is with intravascular imaging. So this basically means that we have an alternative way to image atherosclerosis, and this again in the context of PCI, which I will show you how relevant this is. To make this concept kind of easy and fit the workflow of a patient, we have developed this algorithm. We call this the CT-guided PCI algorithm, and it actually has three main pillars. The first one is what we call a refined diagnostic evaluation, that I'm going to go into details in that regard. Then we have the second aspect, which is the cath lab preparation. So who should do this procedure, what materials are required, and at the end of the presentation, you will understand that in 5 years from today, and I think this is going to be a work that we're going to be doing together, most of the tough decisions in the cath lab concerning calcium modification tools, we need to use them, yes or no, or which one should we use in that particular case, will be answered by CT. And you will see again what the future holds in this regard. And one of the things that we have developed, and this again was developed a few years ago in the context of my PhD thesis, is the fact that we can easily integrate CT in the lab. And we'll show you a few pictures and videos on how actually that is done. And if we understand this algorithm with a little more of detail, you will see again that we're going to start with, of course, patient selection. And this is crucial today because, you know, PCI has evolved into this thing that some people call modern PCI, where the use of physiology is a liberal use of physiology to understand the real benefit and to really refine the indication for PCI in the context of all the studies that you are aware of PCI versus medical therapy. Then the second part of the algorithm, I think it relates a lot to resource utilization, how we can save resources, how we can, you know, reduce the number of perhaps guidance that we need to use during the procedure, because you upfront select the right tool for that particular patient, understanding what the best projection that can be used or should be used to visualize that particular lesion, again, having repercussion on the amount of contrast that you'll be used, the amount of radiation, etc. And again, the last part I'll be talking about is how to really use the CT to guide stent implantation, specifically looking from where to where you have to stent, how well the plaque should be prepared, and how to use the CT live during PCI. So if you're an interventional cardiologist and you have joined this grand round, everything you need to know about CT will be shown in the next slide. So you don't need to go anywhere else. So you're in the right place. And basically, this is everything you need to know. And again, for us that we're doing mainly invasive treatment, we don't need to focus on the diagnostic question. That is a question that is answered again in a different phase of the patient journey. Now the patient has been sent to the cath lab. So the number of questions that we're going to ask the CT are completely different. And what you have on the screen is everything you need to know. And I'm going to explain you in detail what are the things that you should be aware. So these are the names of this reconstruction, just to speak the same language. So we call this VR, or volume rendering. Then we have this a second projection that we call 3D MIP, which is extremely useful to understand the amount of complexity and is very simple to interpret. Then we have the actual images that for cath lab purposes will be used to select especially the guiding catheters. Then we have the curve MPRs we're going to use to assess stenosis, and of course, how long the normal to normal segment is, and if we can stent, where should we start and stop with stents. And then, of course, the cross-sectional view, which offer a similar information to the one derived from either IVUS or OCT, and that helps triggering other actions, and I'm going to go in depth into that particular cross-section. So if you go one by one, again, I use this just to understand the anatomy very quickly. This is very good as well, sometimes to understand myocardial bridges. You don't want to stand a bridge. You don't want also to land on the bridge. There is some reports that can lead to perforation. So this is a very simple reconstruction that takes 10 seconds, 20 seconds to look at and understand all these things are written on the slide. But actually, I would like to focus on this 3D MIP because this is a reconstruction that is fully automatic by any scanner. Since a few years, I have asked the team of radiologists in my hospital to put this in the PACS as the first picture in every case. And that resulted in that every single interventional cardiologist in our team, before they step in the lab and the patient have a CT available, they take literally 10 seconds to look at this projection. And it informs me a lot about the disease of the patient. Here on the left side, there is a very simple tight proximal LAD stenosis that is a very simple PCI. There is no calcium, and this is a PCI that you should allocate in terms of logistic organization no more than 15 minutes. On the right side, you have the complete different disease. It's a very complex disease that's going to take quite some work in terms of calcium modification, and this is a procedure that easily could take 1 or 2 hours in the lab. And again, this is one of the ways that we're using CT to actually try to improve the patient workflow in the Cath lab. Now, if we move down to the number of images that I told you that is all you need to know, we're going to the actual images. The actual images are very important in the diagnostic phase. In the PCI planning phase, we mainly use them to select the guiding catheters based on the takeoff of the ostium of the coronary. In the middle of the slide, you have the normal takeoff of the right and the left coronary artery. So the right coronary artery should take off around 11 o'clock and the left coronary artery around 4 o'clock. Everything that deviates from this takeoff will be abnormal. Now, I brought you an example of an abnormal right coronary artery. This is not a coronary anomaly. This is just different position in the aortic root, but this makes a difference in the terms of the catheter that you have to select in order to have sufficient support. And the same applies to a left coronary artery. So what we have learned is that beyond measuring diameters to also select the curve of the catheters, if the takeoff of the right coronary artery, for example, is normal at 11, a JR will do just fine. But if you're working with an anterior takeoff of the right coronary, again, you will need an implanter. These are small information, but I think it helps in the sense that you don't have to change sometimes the guiding. You start with the appropriate guiding from the beginning. Now on the left coronary artery, the same applies. If you have a left coronary artery that has a posterior takeoff, it's better to go with an extra backup catheter, and the others are easily cannulated with the Jodkins. This is an example of an anterior takeoff of a right coronary artery. This is, again, not infrequent in the lab. And if you are going to perform a complex intervention or this vessel is calcified, you surely would like to have sufficient support. And this, again, is not provided by, for example, the Jodkins that you see on the screen that is not really have sufficient support. Now, when we move to the next reconstruction that we call this the curve NPRs, curve NPRs are crucial because they inform about the extension of the plaque in the longitudinal plane. And based on the NPRs, you will be able to understand where is the best landing zone, either proximally and distally. This is a very nice case. There was a tight lesion in the prox LAD. You can see the tight lesion in this cross-section with a very high plaque burden, a high lipidic component. But when you see proximally, and this is the bifurcation with the left main, you see that there is a huge lipidic plaque here at the bifurcation of the left main, and you might be tempted to kind of land in the proximal LAD, but if you do that, you'll be landing exactly at the level of the lipidic plaque. And if you're not using intravascular image for this case, you will completely be landing in a place that will be more prone to dissections and later target vessel failure. So again, understanding the plaque extension in the NPR's lipidic disease allows for tailoring, again, stent length as we do with intravascular imaging. I just want to make here a parenthesis on we talk about length, and I have to say that for a length, CT is the gold standard. It's better than angiography, of course. It's better than IGUS, and it's better than OCT because you're measuring the length in the three-dimensional space without the influence of any device in the coronary vessel that sometimes changes the configuration of the vessel. is not the same for diameter. What you have on the slide is a comparison of the diameters measured for the same vessels at the same lesion with CT in blue, IVUS in red, and angiography in gray. So you will see here that CT will underestimate the size of the vessel compared to IVUS. And we can come back to this concept at the end because it also depends on how the CTs are acquired and how thoughtful the acquisition is done with the use of high doses of nitrate. And then we come to the last part of this cross-section that you need, of this reconstruction that you need to know, which are the cross-sectional view. The cross-sectional view, if you're familiar with either IVUS or OCT, this is exactly the same. You can classify the plaque in either lipidic, fibrotic, or calcified. But what I found is sometimes easier for identifying the composition of the plaque compared, for example, with IVUS, is that you can use these Hounsfield's units that are helping you identifying the intensity of the plaque and classifying the intensity of the plaque. For example, lipids have very low Hounsfield's units, calcium have very high Hounsfield's units, and fibrotic is in between. So you can basically just scroll with your mouse, and the way that this is measured is that you put the mouse on top of any position in that particular cross-section, and the software will tell you where the Hounsfield's unit, and just by doing that, you can understand the composition of the disease. There are a number of studies looking at how good CT is to, for example, assess different plaque components. I show you one simple example to convince you that is everything that you need. If you look at the second cross-section from left to right, you will see that there is a calcific plaque here from 3 to 6 to 7, and you see exactly the same calcific plaque with the same arc with IVUS. And I put here a couple of cross-sections with virtual histology in the middle. The same applies for the third cross-section from left to right, and you see a beautiful cross-section here with a fibrotic plaque, again, showing exactly the same with IVUS. So again, CT is in a moment today, and I think it's going to get even better, that is able to understand the composition of the plaque in a very precise way. In addition, what really matters for the PCI procedure is to understand the landing zones. And you see here that you can really see when the vessel is really healthy. Don't forget that CT has a 98, 99 negative predicted value for a healthy coronary. So that is one of the advantages, and that is one of the reasons why we have extrapolated the concept of normal to normal to CT. Now, let's move from anatomy to physiology. And physiology by CT, you are familiar already with this type of blood flow simulation. This is a very simple technology in the sense that once you have extracted the three-dimensional geometry from the CT, you just simulate blood flow, making a couple of assumptions. You make assumptions about the CFR, for example, and based on that, you calculate pressure drops along the complete vessel. Now, you have, of course, been familiarized with the fact that if it's red, it means that the flow is reduced, so the FFRCT is low, and if it's blue, it's because the flow is high. So basically, this is the color-coded what you need to know about FFRCT. Now, where this technology actually becomes pretty interesting is trying to assess what would be the response of that particular patient to PCI. And that depends on the pattern of coronary artery disease. So we know that if we have diffuse functional coronary artery disease that you see on the left side of the slide, we know that the response to PCI is actually not as good as if you were to perform PCI in the patient on the far right of the screen for all these four LADs. And you see here a gradual change in the pattern from left diffuse to the right focal. And again, when you do a PCI in the case on the right side with focal disease, you completely restore the flow. I'm going to talk about that in a little. So to understand this concept, and this is a completely new concept, I have to say that the team of the Cath lab, Yadar and Manos, are performing this on a regular basis with invasive physiology. But basically what they are doing is mapping what happens in the coronary in terms of flow or pressure reduction along the vessel's length. And to illustrate this concept, we're going to use this cartoon where we're going to measure FFR in the distal part of this LAD, and this FFR in this case is 0.7. But if you pull back the pressure wire, we call this a pullback maneuver, And you will see that when the sensor crosses a focal lesion, there will be a great step in this curve. And this is what we call a translesional pressure gradient. This is, again, this is nothing new. I have to tell you that Andreas Grunsig was doing this in 1979 to identify patients candidates for angioplasty. And we're coming back to that in 2024. Now, if you see this type of pattern, this is very good. It's very good for you and it's very good for the patient, because when you dilate this vessel and you implant the stent, look at the right side of the slide. This happens. You normalize epicardial conductance, you increase flow, and of course, this leads to improve in myocardial perfusion and improvement in angina. And I'm going to show you the opposite side of the coin, which is diffuse coronary artery disease. Again, the main problem is that we cannot really assess this by angiography because, as you know, angiography is really poor to assess diffuse coronary artery disease. Now, the way that we have to do this in the cath lab is, again, putting a pressure wire, pulling back the wire. The distal FFR is going to be exactly the same or can be exactly the same as focal disease. But when you perform this pullback maneuver, you really don't see any place that is actually responsible for the reduction in perfusion. And that is a problem. I have to be also honest with you. We don't know what to do with this, but we believe that the answer is not PCI. What usually happens here is that you will find a place in the angiography that looks more, a bit tighter than the other place, or if you do intravascular imaging, you will always find a place that the lumen area is smaller. You will end up putting long stents. But anyhow, what happens in this type of disease is this. Look at the right side of the slide. There is a marginal improvement in conductance. The flow remains low. And this is a new paradigm shift in the way that we look at coronary artery disease and invasive physiology. Now, again, this can be extracted from FFRCT. And the concept is that PCI for localized disease really improve blood flow. And in diffuse disease, there is minimal improvement in blood flow. I'll show you the data to support these statements. This is a number of patients that underwent, of course, FFR-guided, but also OCT-guided PCI, trying to cover all the disease. And we have used a new metric developed by our team called the PPG that classifies the disease either in focal or diffuse. PPG close to 0 is diffuse, PPG close to 1 is focal. And in this vertical axis, you have how much did the flow improve with the PCI, and we have, of course, used here delta FFR for that purpose. And this is the plot. It's very clear. And when you look at the statistics out of this plot, specifically at the coefficient of determination is 51%. This translates clinically to that half of the improvement that we can obtain in terms of blood flow with PCI actually depends on the disease of that particular patient. And again, we thought that we could fix everything with PCI. That is not the case. We cannot fix diffuse coronary artery disease, even using what we call modern PCI with intravascular imaging, etc. Now, why is that important? Well, I'll show you again, using the same metric. This is a different population. We demonstrated that patients that undergo PCI, all these are successful PCIs from the angiographic and morphological point of view. But when the patient come back to the clinic, and this is residual angina assessed using the Seattle Angina Questionnaire, more than half of the patients that had a baseline diffuse functional disease pattern will report to remain symptomatic. And this, of course, is significantly higher than in those patients that are treated with PCI but had a predominant focal pattern of coronary artery disease. This extends into safety. And this is a study that was presented by our group at TCT last year. It's called PPG Global. We included 1,000 patients here, and we showed that in-hospital outcomes are worse after PCI when you treat diffuse disease. Particularly, I want to focus on the right side of the slide. You see here the incidence of periprocedural myocardial infarction was doubled in patients that were treated with PCI and had a baseline pattern of diffuse coronary artery disease. And again, you know that periprocedural myocardial infarction is an extremely important entity, at least academically and scientifically, because the reason why the trials showing comparing revascularization with medical therapy have been neutral is because there is a higher incidence of periprocedural myocardial infarction, and these, again, appear to be predominant in vessels with diffuse coronary artery disease. Now, coming back to the CT and understand how this technology can actually be helpful in terms of clinical practice, there is this technology from called the FFRCT planner. And you'll see here that this is a technology that allows you to predict what would happen in the event that you put a short stent or a long stent in terms of the improvement in blood flow in different scenarios. So again, this is it's like a virtual PCI. This is an iPad basically. And I think Yader has already done a few cases in the Cath lab, and the cases have been extremely interesting in terms of the results that you have obtained. I'll show you how we're using this technology. Of course, there is a couple of niches where I think this is a game changer. One of them is serial lesions, to understand what would be the interplay between one lesion and the other, while you treat one and remove the other. So that is extremely interesting in the sense that the technology recalculates the flow rate immediately in the iPad to understand what will be the impacts of the increasing flow on the other stenosis. So this is one of these examples where you can, of course, based on that, tailor the strategy of the PCI to the particular patient anatomy in terms of flow. I'll show you a patient from the P4 trial. We did this patient in a few weeks ago. And again, you will see here that there is a diffuse disease in the LAD with one lesion that is more proximally, a second lesion distal in the mid-segment, another lesion distally. And then what we try to obtain, well, we say, okay, let's put, almost a full metal jacket in the LAD. And then we realize that even after being very aggressive, there was a calcified disease, very aggressive in this LAD, the prediction of the tool was that the post-PCFFR will be 78. So even we're going to leave the patient in the ischemic zone after having all the risk of this very, very long metal jacket in the LAD. And of course, we decided for a different treatment strategy. Specifically, we sent this patient for a Lima. Then again, another case now in the right coronary artery where you see again the effect of extending either proximally or distally the stented area on the increasing flow. And you see here strategy one, which appears to be an optimal strategy based on the improvement in flow. But again, you see that it requires 80 millimeters of stent to achieve this 90 of 89 post-PCFFR. And you see the sharp contrast strategy two. In P4 is a trial that is almost we are including any sort of lesion complexity. And in this particular case, also coming from the trial, I'm showing you how this tool can also be used in very complex disease. In this case, long LAD, left main stenosis, and a diagonal also with a significant lesion, subtending a significant amount of mass. And I just wanted to share with you that this tool supports two-stent strategy. This is a virtual full lot, a PCI, again, stent to the diagonal and stent towards the LAD. Well, how accurate is this tool? We published this a couple of years ago in JACC Imaging. The reference is not on the slide, but we reported that the mean difference between the FFRCT planner and the invasively measured fractional flow reserve after PCI is 0.02 units. So this is extremely accurate a prediction tool with a standard deviation of 0.07 that again has to be accounted for in terms of its imprecision or precision. Now, if you combine everything that we have been discussing until now, here comes the concept of CT-guided PCI. And CT-guided PCI is actually, with the same tool, being informed about the presence of the disease, the location of the disease, the severity of the disease, but also the extension of the plaque, the composition of the plaque that is extremely important for the PCI strategy. And at the same time, understand the physiology associated with it. And you see here on the right side of the slide, FFRCT model with a very focal stenosis in this mid-circumflex. Now, what we have learned from looking at these cases is that you can have even long lesions. This lesion is not short. You will require at least 38 millimeters of stent to cover all this lesion. But actually, this is a focal disease. So there is an anatomical diffuse disease, if you may say that, based on previous definition, but with a focal functional component. And again, the physiology is what matters, because the physiology, again, is what is related to the flow, if you measure fractional flow reserve, and this, of course, is related to patient improvement in their flow and in perfusion. Now, this is very nice, and this is the part that we call the pre-procedural plan. And then we move forward to actually the integration of CT in the lab. To do this, we thought initially to train all our interventional cardiologists in reading CT. But I have to disclose that we failed in doing that. They didn't want to learn how to read CT. There were too many clicks. It was too complicated. And the pilot was, well, it was a failure, but we learned a lot from it. Now, from that initial exercise, we came to the conclusion that we needed to simplify the way that the information is shown to the PCI operator. Then we came with this idea. We basically extracted the lumen. These are the same contours from a simple curve MPR that I showed at the beginning of the presentation. And then we found a way to plot the plaque in 3 dimensions on top of the luminal geometry. And then we just added some colors. And this is the final geometry. And again, it takes literally seconds for any interventional cardiologist without any training in CT to understand what you are looking at. This is, again, a coronary tree with some calcium in the roof of the left main, some calcium in the inferior wall, if you might say, of the LAD. And this, again, crucial information for the procedure. The next step was what I'm going to do in Minneapolis on the 18th of March. So basically, I'm going there to connect these models to your Cath lab. And what we're going to do is synchronize the CT-derived plaque models with your C-arm. And every time that you move the C-arm, you will understand what you are going to see once you put your foot on the pedal in terms of projection, lesion visualization, etc. I have to say that after we have applied this systematically in our lab, I have been really impressed by the constant suboptimal angulations that we use with angiography to work and to do complex interventions. And you understand the three-dimensionality of the tree and how the foreshortening angio view sometimes is completely inaccurate in terms of what you are seeing on the screen. So this is really an eye-opener just in terms of the coronary anatomy. Now I'm going to take you to the current direction where we are. And this is something that is extremely exciting for me because it's really the frontier for CT. And CT, I think, is going to become, as I said at the beginning, the tool to decide whether advanced calcium modification tools are required. And why we do this, and again, for our colleagues that are doing more reading images, calcium is the most important predictor of stent under expansion. And stent under expansion is the most important predictor of stent failure. So if you treat the calcium appropriately, if you are able to fragment or fracture the calcium before stent implantation, that will increase or improve the durability of the PCI result. And that is very important. The main problem, of course, you're familiar with is that angiography is a very, very poor tool to understand calcium. And again, we go back to CT, where looking at calcium is extremely easy. So this is a comment perhaps for Joao and John and the team reading CT. So we have taken a limitation of the tool of CT in general, because if you think about 10 years ago and you think about calcium, everybody was saying, oh, calcium is a limitation. You should not even do coronary angiography when the calcium score is high. Now, the understanding of this has changed 360 degrees. CT is an excellent tool to assess calcium. And I think the more the calcium and the more the calcium is analyzed and understood based on the CT, the higher the likelihood that the procedure will be successful. And the way that we have to look at calcium is basically the same that we use for looking at intravascular imaging. And if you're reporting CTs, there are 3 things that you should mention in your report if you look at calcium. The first one is the circumferentiality of the calcium. So what is the arc of the calcium? This is extremely important for the PCI to avoid external expansion. The thickness of the calcium. And again, this is one of the things that if you're using IVUS, the CT really complements the IVUS by telling you how thick or thin that particular calcium is. And the length, which is also very, very simple to measure in the longitudinal plane. We have validated all this analysis against OCT. What you see now on the slide is horizontal axis all coming from CT, and vertical axis coming from OCT in terms of thickness, arc, and length. And you see that for arc and length, CT is a very, very good tool that, again, to help understanding what would be the probability of underexpansion. Now, let me show you a case to make this, again, more practical. This is a case that has a very calcific LAD from the proximal to the mid LAD. And you see here on the cross-sectional level that at cross-section C, there is a concentric ring of calcium. If you ask the interventional cardiologist what they're thinking now, they will say, we have to focus on the ring of calcium. I have to use IVL or any other tool. But this, you cannot implant a stent without actually fracturing this calcium. And again, if you look at cross-section B, you will also understand that there is an asymmetric but very thick calcium that you have also to modify before stent implantation. Now, this, again, allows for planning not only in terms of the stent length, etc., but also to understand what are the regions that you have to focus in terms of preparation before you actually implant the stent. And one of the things that we have been looking at, and this is, again, one of the next frontiers, I will come back to this concept, is the fact that in addition to understanding circumference, thickness, and length, we can also understand how hard that particular calcium is. And this is actually achievable by measuring the Hounsfield's units, which is basically a measure of how dense that particular calcium is. For example, here, if you look at cross-section E, which is a concentric ring of calcium in IVUS, again, in IVUS it's very easy to see this ring of calcium because it's basically one shadow. You see that the calcium produces a shadow here. You cannot see anything else. But when you look at the CT, you see the ring. But most importantly now, we're able to understand how hard that ring of calcium is. And again, you can have calcium of 1,000 or even 2,000 Hounsfield's units. And then you can have calcium of 700, 900 Hounsfield's units. And that speaks about the density of the calcium of that particular plaque, which is correlated, again, with how hard that calcium would be to break. And again, we also provide this, or we're showing this in the three-dimensional space. So you will understand clearly where are the areas in that particular disease that you will need to focus. And you see here in this example that this calcified ring of calcium is basically just before the bifurcation with the second diagonal. And that is the position where the interventional cardiologist during the procedure needs to focus. The second aspect that I think that the three-dimensional visualization of the disease makes a big difference is understanding what would be the behavior of the particular devices. And I want to show you something that is extremely intuitive, but we don't think this too much because it's so difficult to understand 3 dimensions with 2D images, is that when you actually dilate a vessel with asymmetric calcium, what actually happens is that you will not really move the calcium. What the balloon will expand towards the more compliant part of the vessel. And if you are in a bifurcation lesion, you can clearly here foresee that the balloon will expand towards that side branch. And again, that will increase the risk of a side branch occlusion. I'll show you one of our cases here. You see that there is kind of a calcific structure on the top of this bifurcation lesion. And when you implant the stent, immediately you have a stent that is now protruding towards the side branch with a side branch occlusion, ST elevation, chest pain, and periprocedural myocardial infarction. And if you use this system that I call enhanced angiography, you will see exactly what happened. So this calcium in the bifurcation actually pushed the stent towards the side branch, generating a side branch occlusion, and again, the periprocedural complication. Now, the other important thing that we're deriving from the CT, and this is part of the trial that you're going to be participating soon, is the fact that we can derive the myocardial mass at risk for every segment of the coronary tree. And this particular case is very informative to understand that the side branch, for example, in this case, substantiates about 11% of the left ventricular mass. And again, from the operator's point of view, this basically means that you really need to be careful not to lose that side branch, because that's going to be a relative big MI. Now, again, going back to this particular case, this is what we predicted in terms of strategy 1, 2, 3, or 4. And again, you can choose whatever you want based on the results expected based on each of the strategies. And again, this provides complementary information for the case. I'll show you what we did. This IVL. So we have this again in front of us. We just positioned the IVL balloon where the concentric calcification was present, and then also treated the more asymmetric proximal one. Now, what happened? I'll show you what happened after the IVL. Let me see if my animation plays. We again confirm with intravascular imaging that actually we have fractured the calcium. And I'm going to come back to this point of prediction of fractures with CT. And you see here clearly that we have achieved sufficient plaque preparation in terms of calcium fracture. And of course, this basically means that you're ready to implant the stent. So the way that we see a CT today in this calcific world is actually complementing intravascular imaging by being, of course, non-invasive, allowing for pre-procedural planning, give you the plaque in 3D and in the 3 vessels. Now I'm going to end up with something that we have been working on, and this is going to be in press in a couple of weeks. So basically what we're doing is we are extracting the 3-dimensional structure of the calcium in this way. So for the ones I've never seen this before, this is the calcium, 3D calcium extracted. We have removed the lumen, and you have seen this analysis that we can do basically the classical morphological approach with circumference, length, etc. But what we're now adding to this again is how hard that calcium is. And what you see on the top is actually a distribution of the calcium density in every circumference. And of course, the higher the density and the more homogeneous the density is in these calcific rings, the harder it is to break them. And this, of course, the next step will be validating or what is the threshold to say this is a case that needs to be done, for example, with IVL or another plaque modification tool because the density of the calcium and the distribution of the calcium are too severe. Again, we already discussed this, but one of the things that we're working as well is to understand where would the wire, the coronary wire, be located inside the vessel. Why we're doing that? Well, you know that there is something called wire bias. So sometimes the wire is actually not touching the calcific structures, and this is a problem if you're thinking of using tools like rotablation, etc., that are basically the mechanism of action is contact between the wire or the device that you have to add on top, that is the burr, and the calcific disease. So we're trying to predict what would be the best device to select. And here you see an example. This is one of our first prototypes showing how you can simulate the wire position in the coronary. The wire is depicted here with the green dash line. And again, you see where the calcium is located and how much of that calcium will be actually modified with an ablative tool like rotablation. I'm going to finish with a last couple of scenarios, which I think that CT is also a game changer. And this is, again, bifurcation lesions. Again, you can understand the complexity of the disease, not only in terms of the anatomy, but also the calcium. And then you have next to it the physiology, which again informed you about the potential outcome of that particular intervention. And you have the mass again, which helps you understand how aggressive you need to be in terms of protecting that side branch. I will go fast. This is the case, again, showing the different strategies. So we thought that strategy 1 was suboptimal because the diagonal is subtending 12% of the mass, and we will leave that severely ischemic. So we decided to do a 2-stent strategy. Basically, we selected the guiding based on CT. We did the plaque preparation based on CT. And finally, we used the model during the procedure to be sure that the length of the stent that we chose for each of the steps of the procedure were not overlapping in front of the side branch to make the PCI, the purification PCI easier and making recrossing to the side branch easier. So this is, again, some of the examples on the way that we use CT. Finally, I think I have to mention something that is came into the literature a couple of months ago, which is using CT for CABG planning. And these are not for CABG, but for patients that are referred to the Cath lab after CABG. And it makes a lot of sense for the reasons that are on the slide. You know, it's easier to understand what is the anatomy, if they're already the bypass are open, if the lima is open, which is the access that you need to do. If you have already information about the lima or the rima, you probably can do that procedure radially, etc. I think it's a lot of benefit of planning this procedure with CABG. I'll show you a quick example. This is one of the cases included in the CABG bypass trial. showing again that if you have this information beforehand, it's extremely easy to kind of go directly, cannulate the bypass and treat this particular vessel if that is a target. And again, the trial showed a significant reduction in MACE when you plan these procedures upfront with a CT, and this has been published in Circulation a couple of months ago. So to close the presentation, I think this is all the information that we have from CT relevant for planning. I will not go into each of these reconstructions. We have seen this extensively through the talk, but again, you can understand the device, the disease complexity, selecting material, understanding calcium, and be prepared to really have the plaque well prepared before stent implantation, the mass at risk, the angulations, the physiology, and the prediction of outcomes. Everything that you have seen in the previous slide is being used in the P4 study. We're actually including 1,000 patients, which we're going to randomize them into one arm that is this CT-guided PCI concept. And we will compare that with a group using IVUS-guided PCI that we believe today is the gold standard for doing PCI. And again, this is a clinical study with MACE at 1 year as an endpoint. So to finalize, I think that coronary CT is not anymore a diagnostic tool only. CT has expanded, now has a huge role in pre-procedural planning. We're in the mid of this randomized trial. We have 500 patients included. We have been learning a lot. And I think it complements not only the angiography, but also the other imaging techniques that we have. I think we will be able to enhance the selection of materials, and this is going to be a game changer for calcific disease. And again, I think that we believe that integrating this into every patient workflow will have repercussion and will improve patient outcomes. With that, I think I will just leave you with a couple of pictures of our last courses of CT for interventional cardiologists. This is the picture that I got when Yader came to us. So this is really an intensive 2 days course to really understand how to use CT for PCI guidance. And we're going to have our next edition. It's a yearly edition now, June 24 and 25th this year. So if any one of you are interested, please feel free to contact me. And with that, I would like to thank you for your attention.
Carlos, that was just a wonderful. Thank you so much for that presentation. Very enlightening. I love PCI. I love what I do in the Cath lab, but let me tell you, after that presentation, really it makes me think I should be an imager. That's just wonderful. So, number of questions already online here. We'll start with online and in person. So actually, I see our good friend and colleague, Dr. Jiang Lasser, has a number of questions. So I'll start with the first one. I don't know whether you can see the questions, but the first question is, how much do you use CT for stent sizing? And is there a difference between proximal and more distal?
Yeah, that's a very good question. So we use CT for length all the time, okay? So length, yes. Now, when it comes to diameter, there is a couple of things that you have to keep in mind. The amount of vasodilation that you have during the CT acquisition is crucial to really derive accurate measurements. We have seen in the trials that we have done that 800 micrograms of nitrates or 2 sprays are given a good accuracy in terms of diameter. If you use 400, or if you don't use nitrate before CT acquisition, forget about that. It's going to be too small, and it will not really be accurate compared with intravascular imaging. So how much are we using that, John? To be honest with you, we don't rely on CT to assess diameters, although we have a paper coming on left main and to select the balloon for proximal optimization, the left main, and it appears to work pretty good in the left main because it's bigger. The amount of voxel per image is significantly more, and it appears to be the more accurate in larger vessels. So that's a bit the trying to answer your question.
Thank you, Carlos. I'll switch here to Dr. Cavalcante, who says it's an excellent presentation. Thanks for leading the field. I'm looking forward to your visit. How do you foresee interventional cardiology training given these developments, and what initiatives do our societies need to implement?
So I think that the training for an interventional cardiologist is completely different from the classical training to read a CT. And again, it goes back to why are we doing this? And the reason is not really, we're not making a diagnosis. the diagnosis is already made, the patient has been referred to the cath lab. It's how we use the information that was already acquired to make my procedure more efficient and with higher chances of success. So I think we will need to define a complete new curriculum. And I think that, well, Yadar is joining our weekly calls. We have a weekly call in the P4 trial where we present the case and we learn together with the case. And I think this is going to be the basis of what we need to really learn, and after that, teach to all the interventional community about CT. And again, it goes to very practical imaging aspects of the image that can be used to guide the PCI.
Another question here from Dr. Lesser is about the guide catheter size, where you have retrospective of the guide catheter size used and correlated that with the CT-derived diameters and the angles and aortic sites, whether you can potentially have virtual placement of a catheter to guide that.
Well, so yes, we have looked at that, and we have also looked at how many cases in our lab we have to use a second guiding, and the amount is like 20% of our cases we need a second guiding, and this is something that we believe is going to be really reduced if you select the guiding based on CT. The second part of the question, there is already a Japanese company with a virtual reality tool that enables you to really see how the catheter sits in the aorta. And I think it's going to be extremely useful for, interventions in post-bypass patients. For the interventions, let's say in the native coronaries, I think just looking at the diameter in the aorta and the takeoff of the coronary is sufficient.
Perfect. Our interventional colleague, Dr. Plaque, says, excellent talk. What about radiation dose? What about photon count in CT? Any thoughts on that, Chris?
Yeah, so I think that, and perhaps maybe John or Joao can complement this, but we have come into a phase where a coronary CT acquired in normal workflow delivers a very small amount of radiation. And I think that some of the scans that we have in the trial are below 1 millisievert with a medium of 2 to 3 millisievert, depending on the conversion coefficient that you use. So I think that this is a very safe exam in terms of radiation exposure. If you compare that with the radiation that we give in the cath lab, this is significantly more. So this led us to think, Manos, that in the trial, we think that the patients that are having this pre-procedural planning with CT will have less number of projections, because you basically know exactly the projection that you're going to have the best visualization. Second, the pre-planning aspect will make you more efficient, and perhaps this will lead to lower radiation. So we are thinking that overall, the amount of radiation that the patient will receive will be lower when the procedure has been planned based on CT.
Perfect. Another question from John. This is a very interesting question. What about do you have a heart team with imagers and interventionalists and surgeons who review the images together, or do the interventionalists do it alone with that understanding of CT? And I'm interested in a question myself, because I think, we've debated about this quite a bit as well. We have such a strong relationship with our imagers, Dr. Lesser, Cavalcante. I can tell you that they were, holding our hands early during their experience, trying to learn all the softwares and all these tools. And of course, as you become more comfortable, you also learn a lot looking at this independently. So what's the vision for this? Is this a team approach, or eventually interventionalists drive it?
Yeah, I think it's both. And I think that the role of having the CT in a heart team discussion really helps and inform the discussion. And 2 weeks ago, I was in the UK visiting a hospital called Barts, and they have adopted CT in the heart team discussion. So they start discussing the case, they put the CT, they look at the anatomy, then they take the planner, then they see the post-PCI prediction, and then they take a decision whether the patient is for PCI, surgery, or medical therapy. And I think that if I think of any other institution in the world where this could be, really a change in the internal patient discussion, is in Minneapolis, because you're close to each other and you have, very high level of expertise in all these fields. And I think that I will throw the question back to you guys, and I think you should help lead the way to really embed CT in the heart team discussion. And I can tell you it makes a lot of sense.
question that actually follows nicely that point, and actually I had an annotation in that as well. Is one of our other interventional colleagues, Dr. Nick Berg, who asked, how often do you find that CT directs away from PCI and towards bypass? And I'll add to that because I know that I had made on this. I really have enjoyed all your publications and data on the PPG and disease pattern. And I think what happens right now is that right now, it's more a binary approach in which you say abnormal CT, you go to the Cath lab. But now it's sort of like, that ship has sailed. There's expectations to come to the Cath lab, maybe even expectations about revascularization. But should that information be used even beforehand by the non-interventionalists to already say, like, this is something that maybe I should send to the surgeon, or maybe we should focus more on medical therapies? I'm interested in that.
Yeah, that's a very good question. So I don't have the answer, but I'll tell you our experience. So when we started working with the planner, we quickly realized that there were interventions that we were doing that were very suboptimal in terms of the amount of flow we were restoring, either with long stent or with short stent. But we're really uncomfortable by, measuring FFR after the PCI and realizing that was low, and you don't see any other lesion to treat based on the angiography. So that started by our couple of surgeons called me and said, we want to have the iPad in our consultation because, you're doing a lot of PCIs and sometimes it's not the best treatment option. So now what that expanded to is a couple of clinical colleagues that are basically using the planner and talking with the patient saying, listen, we believe that PCI is not the best approach. Your symptoms are under control of medical therapy. We're going to keep it like that. And then you have also the surgical argument saying, if this will be treated with PCI, you will need 120 millimeters of stent. The FFR will be even suboptimal. Maybe you're a better candidate for surgery. So I think we're slowly moving towards a more informed decision making based on the prediction with this tool that's going to get better and better and better. And I think that's the future. Who is going to hold the planner? Yader? I don't know. If it's going to be John and Joao talking to the patient, or you and I in the Cath lab, that's another question. And we don't know how this is going to evolve, but this certainly is going to be part of the discussion in the future.
Another one from John here says, how much were KV changes altering your calcium Hounsfield unit measurements? Do they make frequent patient-dependent changes in your CT lab?
Yes. So yes, let's start with the last part. So every time that we have a lot of calcium, and we do always calcium score just for this purpose, we increase the KV. We're going to 140 now. That really helps delineating calcium, or you can 120, which is more or less standard. So this is what has changed in our practice in terms of acquisition. Now, we don't really rely too much on absolute Hounsfield units cutoff. And this also answers the question of Arum in the chat. You have really a concentric structure of calcium, what really matters is how heterogeneous that calcium is. In other words, do we have a quadrant with low Hounsfield unit and a quadrant with high Hounsfield units? If that is the case, that's going to be an easy calcium to fracture because there is a region that is weak in the calcific circumference. If the calcium is homogeneously hard, in other words, Hounsfield units are super high and really the same along the circumference, that is a completely different structure. So we are rather basing this type of analysis and decision, this is not yet published, on the changes of calcium within the arc of calcium. And that we're learning a lot about how calcium forms, how calcific rings actually develop doing this analysis.
And Carlos, as I've alluded, actually our grand rounds are available virtually online to anybody. And actually, one of our colleagues here from Minneapolis, from another practice who has joined us online, is asking whether you can give some examples about potential limitations where the CT-guided PCI may not work or underperform, or whether it can give you some pause in any particular situation. And I'll add to that one that I have made a note is that, for example, with even Planner or other tools, sometimes previous stents add some limitations. So interested in your thoughts on that.
Yeah, so the straightforward limitations are stents. Of course, there was a question about CTOs. The Planner, for example, doesn't work on CTO, so you cannot really use it in the prediction system in the CTO field. And again, here, the image quality is what plays a big role. So you need to have a very good scanner and a very dedicated people being sure that the quality of the image is sufficient. Now, we are talking, everything that we have been discussing is in stable coronary artery disease because you have, sufficient time, you have a symptom, you go to the clinic, you get the CT, etc. Now, in my view, what I think is going to be a group that we haven't really addressed so far is the patients presented with acute coronary syndromes, where the time is a little bit shorter. And that will be, again, one of the groups that we don't know if that's going to be feasible or not. But this is, part of trying to answer your question, what are the subgroups where these have been explored or not, and what to foresee in the future.
Any other questions? Yeah, Carlos, this has just been wonderful. All of the work that you and your group have been doing this, it's inspiring, and the opportunities that exist in this field. We're greatly appreciative of the partnership. I look forward to having you here in Minneapolis twice for the P4 site initiation, and also for supporting us with our course that we'll be doing in April. So thank you so much, Carlos. Excellent Grand Rounds.
It's a pleasure for me, Yader. Thank you very much for the invitation. And I have to say that I'm very honored and grateful on the collaboration with all the team of Minneapolis. And this is a completely new field, which I think our partnership will be as crucial to push this field together for the future, to improve all the things around CT, PCI, and of course outcomes.